Auzubillahiminash-shaytanir-rajim. Bismillahir-Rahmanir-Rahim. It's a continuous series of 10 pages at a row regarding obstetrics. Start with this. Pregnancy changes. Pulmonary changes in the pregnancy. In here, patient may come with dyspnea on of pregnancy. Dyspnea of pregnancy, there is increased partial pressure of oxygen and decreased arterial carbon dioxide. Increase PaO2, increase arterial oxygen and decrease arterial carbon dioxide. There is respiratory alkalosis. So in clinical feature, if a woman came with dyspnea and you do ABG and you found respiratory alkalosis, it probably due to, and we know that in pregnancy there is changes in the hormone level. So progesterone may cause hyperventilation. So this is progesterone induced hyperventilation. Lung volume increase, minute ventilation increase, residual volume and normal vital capacity and FEV1. So in here there is increased minute ventilation, increased residual volume. The hyperventilation creates an expected respiratory alkalosis with metabolic compensation. PaCO2 typically decreases to 27 to 32 millimeter of mercury, and there is a compensated decrease of bicarbonate to approximately 20 milliequivalent to keep the expected pH in the high normal range. The hyperventilation also slightly increased the expected PO2 to approximately 110 millimeter of mercury. This is the lung volume. So in pregnancy, tidal volume increases, inspiratory capacity increases. Vital capacity is normal, but expiratory reserve volume, functional residual capacity, and residual volume decreases. So in pregnancy, tidal volume increases, inspiratory capacity increases, resid vital capacity is normal, and expiratory reserve volume, expiratory reserve capacity, and total lung capacity is decreased. This one is very high, should not be overlooked. In pregnancy, in asthma in the pregnancy, there may be severe asthma prior to pregnancy. There may be obesity, excessive first trimester weight gain, and smoking during pregnancy. In clinical feature symptoms, cough, wheezing, shortness of breath, chest tightness, worse at night, precipitancies, upper respiratory tract infection, cold air, allergy, and exercise, and complication is preterm delivery, LBW, and antenatal hypoxia. In healthy, sabasalbutamol and schedule ICS, fluticasone. Sometimes systemic corticosteroid prednisolone can be used in acute exacerbation. Wheezing may be absent outside the attack. Asthma control is essential for avoiding maternal and fetal complications like preterm delivery, low birth weight, and antenatal hypoxia. Most therapies are safe and generally involve inhaled short-acting beta agonists, albuterol for acute symptom, and inhaled corticosteroid are required for daily persistent symptom. Oral corticosteroid or oral corticosteroid prednisolone may be required for acute exacerbation. Gestational asthma can be confused. Gestational asthma can be confused with dyspnea of pregnancy, a common physiological cause of shortness of breath, likely due to why, why, why dyspnea of pregnancy happening due to progesterone stimulation, progesterone-induced stimulation of the medullary respiratory center. Although it worsens during the second trimester, dyspnea of pregnancy is persistent rather than intermittent and not associated with diurnal variation. It would not explain this patient's cough and chest tightness. So in asthma there is cough, chest tightness, wheezing present, but in dyspnea of pregnancy it is persistent, just like air hunger. Maternal cardiopulmonary adaptation to pregnancy. Maternal adaptation, cardiac, increased cardiac output, increased plasma volume, decreased systemic vascular resistance. Cardiac is increased cardiac output, increased plasma volume, and decreased systemic vascular resistance. And in respiratory, there is increased tidal volume, decreased functional residual capacity. Tidal volume is increased, functional residual capacity is decreased. As there is elevation of the diaphragm, functional residual capacity would be decreased. What are the clinical manifestations? There may be peripheral edema, there may be low blood pressure, high heart rate, systolic ejection murmur, and dyspnea. Nocturnal leg pain is common due to muscle cramping from lactic acid and pyruvic acid accumulation. It happens due to lactic acid and pyruvic acid accumulation. Reassurance and routine prenatal care are indicated. Reassurance and routine prenatal care are indicated. Hypocapnia is a normal phenomenon of late pregnancy caused by direct stimulatory effect of the progesterone on the central respiratory center. These leads to increased respiratory drive, hyperventilation, and chronic respiratory alkalosis. So hypocapnia leads to increased respiratory drive, hyperventilation, and chronic respiratory alkalosis. Physiologic changes in the pregnancy. Cardiovascular, there may be increased blood volume, increased heart rate and cardiac output. There may be decreased systemic vascular resistance. In physiologic changes of pregnancy, there may be increased blood volume, increased heart rate and cardiac output, and decreased systemic vascular resistance. In pulmonary, there may be increased central respiratory drive like hyperventilation, increased central respiratory drive, and decreased PaCO2, decrease That means respiratory alkalosis and PaO2 increase partial pressure of oxygen. In case of renal, there is increased renal blood flow and urine output, increased GFR, decreased BUN and serum creatinine, increased bicarbonate excretion, decreased serum excretion, like increased ADH excretion. Hematologic hematologic is prothrombodic coagulation factor, increased prothrombodic coagulation factor, and decreased hemoglobin concentration. Pregnancy make marked vasodilation, systemic vasodilation that lowers the blood pressure 5 to 10 millimeter of mercury during the first trimester. Blood pressure generally returns to the pre-pregnancy level during the third trimester. Rheumatic mitral stenosis is an insidious progressive disease, and physiologic hemodynamic changes during pregnancy can cause precipitate symptoms. In previously asymptomatic patients, the new AFib can further increase transmittal gradient and left atrial pressure with worsening of coingestion and pulmonary edema. Peripartum cardiomyopathy causes rapid onset systolic heart failure, fatigue, cough, pedal edema more than 36 weeks of gestation. In the early puerperium, physiologic hydronephrosis of the pregnancy. Hydronephrosis begins during the first trimester as high level of progesterone can cause urethral dilatation and decreased peristalsis. Hydronephrosis begins during the first trimester as high level of progesterone can cause urethral dilatation and decreased peristalsis. Right hydronephrosis is more pronounced due to dextrorotation of the uterus, which causes increased compression of the right ureter. Physiologic hydronephrosis of pregnancy require no additional management. Non-specific common symptoms of the pregnancy include urinary frequency, nocturia, back pain, round ligament pain. Postpartum endometritis. It may be due to cesarean delivery. Chorioamnionitis group B, cervical inflammation. In postpartum endometritis, there is cesarean delivery, chorioamnionitis, group B, streptococcus colonization, group prolonged rupture of the membrane, and operative vaginal delivery. Fever more than 24 hours of postpartum uterine fundal tenderness and purulent lochia. Then we have polymicrobial infection. Postpartum endometritis caused by polymicrobial infection, Clinda genta. In postpartum endometritis, there may be caesarean chorioamnionitis, colonization, caesarean delivery, chorioamnionitis, and colonization of a group streptococcus fever more than 24 hours of postpartum uterine fundal tenderness and purulent lochia. There may be polymicrobial infection. Treatment should be continued until the patient is febrile for more than 24 hours and their blood or endometrial cultures are required for the diagnosis, and further evaluation is indicated. No clinical no clinical symptom after 48 hours antibiotic therapy. Now endometritis, it's a polymicrobial infection within the endometrial cavity, can present with chronic pelvic pain, abnormal uterine bleeding, postcoital or intermenstrual bleeding rather than dysmenorrhea. In addition, patients typically have chronic superficial surgical side cellulitis can occur after cesarean delivery, can present with postpartum fever more than 38 degrees Celsius for more than 24 hours after delivery, as well as incisional duration and erythema. There may be incisional erythema and risk factors include obesity, emergency surgery, is with vaginal cephalosporin because of the cover common in skin pathogens with hemolytic streptococcus MRSA and septic pelvic thrombophlebitis. In septic pelvic thrombophlebitis, pelvic that means pelvic surgery. There may be sepsis. So endometrium, maybe septic endometritis, pelvic inflammatory disease, and pregnancy, malignancy, and pelvic surgery. So pelvic ward is related to pelvic surgery, pelvic inflammatory disease, endometrium is involved, endometritis, pregnancy and malignancy. There may be hypercoagulability, pelvic venous dilatation, there may be pelvic venous dilatation and infection, fever unresponsive to antibiotic, no localizing signs or symptoms, negative localizing. Diagnosis anticoagulation and broad spectrum antibiotic and SPT because it is either pelvic surgery or the postpartum period. It's a thrombosis of the deep pelvic or ovarian veins becomes infected. Several factors predispose in septic pelvic thrombophlebitis. There will be anticoagulation and broad spectrum antibiotic. The next step is Korean is very emergency topic. Prolonged rupture of the membrane more than 18 hours, preterm pre-labor rupture of the membrane, prolonged labor, internal fever or uterine monitoring device, internal fever or uterine monitoring device, repetitive vaginal examination, presence of genital tract pathogens, presence of genital tract pathogens. There may be prolonged rupture of the membrane, preterm prolonged rupture of the membrane, prolonged labor, internal fetal or uterine repetitive vaginal examination and presence of genital tract pathogen. These criteria, these diagnostic criteria, oh my, this is very high. That maternal fever plus what of the maternal fever plus fetal tachycardia, maternal leukocytosis, polyamnionic fluid. Lots of question came from just this topic. That what is chorioamnionitis, prolonged rupture of the membrane more than 18, preterm prolonged rupture of the membrane, prolonged labor, internal fever or maternal outdoors. Prolonged labor, internal fetal or uterine monitoring device, repetitive vaginal examination, presence of genital tract pathogen. Maternal fever plus one of the following: fetal tachycardia, maternal leukocytosis, and purulent amniotic fluid. Broad-spectrum antibiotics and delivery complication is PPH and endometritis. PPH and endometritis neonatal is preterm birth and pneumonia. Preterm birth pneumonia and encephalopathy. Preterm birth pneumonia and encephalopathy. Fetal tachycardia more than 160 for at least 10 minutes. Broad spectrum antibiotic is ampicillin, gentamicin, and clindamycin, and immediate delivery. Intraamniotic infection is increased risk of maternal morbidity, sepsis, DIC, and sepsis, DIC, and mortality that outweighs the benefit. Antibiotic acetaminophen, IV fluid are administered to reduce the maternal fever, in which in turn improves fetal diabetes. Seizure or in delivery is reserved for standard obstetric indication, non-reassuring fetal heart breach presentation, and prior uterine surgery. Preventing neonatal group B streptococcal infection, rectovaginal culture, 36 to 38 weeks of gestation. 36 to 38 weeks of gestation. Indication is GBS, bacterial group B streptococcus bacterial group B UTI in current pregnancy. Group B streptococcus positive on rectovaginal rectovaginal in current pregnancy and unknown GBS plus one of the following: less than 37 weeks of gestation, interpartum fever and rupture of the membrane more than 18 hours. More or less than 37 weeks of gestation, interpartum fever and rupture of the membrane more than 18 hours. Prior infant with early onset neonatal GBS infection, intrapartum prophylaxis, IV penicillin. Some patients who do not go GBS screening because they are considered to have persistent heavy GBS colonization. Markers of the heavy maternal colonization includes GBS asymptomatic bacteria or GBS UTI in the current pregnancy regardless of treatment. Another marker for heavy maternal GBS colonization prior to delivery is early onset neonatal infection regardless of screening. Maternal colonization GBS can be transient and therefore screening is performed 3 to 5 weeks before the estimated delivery date and predicts maternal GBS status at delivery because most women delivery by 42 to 40 weeks of gestation. Screening is at 36 to 38 weeks of gestation by rectovaginal culture. In patient with penicillin allergy, intramnotic penicillin is chosen on risk for is chosen based on risk for anaphylaxis. Patient with low risk for anaphylaxis receives cefazolin. Cephalosporin have lower risk of cross activity achieve the same high bacterial concentration in the amniotic fluid with fetal toxicity in GBS positive patients with severe penicillin allergy. Dual sensitivity of the GBS and isolated clindamycin or erythromycin is performed because erythromycin is resistant to is acid-inducible clindamycin resistance. Intramnotic penicillin with vancomycin. Patients who are resistant to clindamycin or erythromycin for whom sensitivities are unable, intramnotic penicillin with vancomycin is often given. In GBS patient with penicillin allergy, clinda and erythrois are performed because erythromycin resistance is associated with inducible clindamycin resistance. In patients who are sensitive to both, intramnotic clinda sensitive to both intramnotic penicillin is with clindamycin. In patients who are resistant to clindamycin or erythromycin whose sensitivities are unavailable, intramnotic penicillin and vancomycin should be given. Asymptomatic bacteria, very high L topic, more than 1 lakh colony forming unit per ml bacteria. It may be risk factor of pre-gestational DM, history of UTI and history of UTI, and the third one is multiparity. E. coli, Klebsiella, Enterobacter group, Staphylococcus, Cephalexin, Amoxicillin, Clavulanic, nitrofurantoin, and fosfomycin can be given. Fosfomycin is a single dose asymptomatic bacteriuria. Cephalexin, amoxicillin, clavulanic acid, nitrofurantoin, and fosfomycin. In contrast, pregnant women who have increased risk of pyelonephritis and complication preterm delivery and low birth weight associated with asymptomatic bacteria. In who have increased risk of pyelonephritis and complication preterm delivery, low birth weight associated with asymptomatic because asymptomatic bacteria during pregnancy increase risk of pyelonephritis. All patients require urine culture screening at the initial visit and treatment as indicated. A repeat urine culture test of cure is performed. After antibiotic completion to ensure clearance of the bacteria. Patient with negative repeat urine culture may resume routine prenatal care. In contrast, those positive urine culture require retreatment and another test of cure. Daily antibiotic suppression may be indicated in patient and with persistent bacteriuria on repeat urine culture and or acute pyelonephritis during pregnancy. TMPS mix is safe in the second trimester but contraindicated in the first 10 weeks because it interferes with folic acid metabolism and it's critical early development. TMPS mix can be then given in second trimester. It is contraindicated in third trimester due to neonatal cardiac. So TMPS mix is a very good cheap drug, but problem cannot be given in first semester, cannot be given in third trimester, cannot be given in first semester due to due its interferes with folic acid metabolism and cause critical early fetal development and cannot be given in last trimester because it can cause neonatal cardiac arrest. So asymptomatic bacteriuria positive culture more than 1 lakh colony forming unit in asymptomatic patient. Screening done usually for 12 to 16 weeks of gestation. Treatment reduces the progression to UTI and complication. Preterm birth, low birth weight, nitrofurantoin for 5 to 7 days, amoxicillin or amoxicillin clavulanic acid for 3 to 7 days, fosfomycin, single dose, no fluoroquinolone in any trimester, no TMP SMX in first and third trimester. In acute cystitis, treatment is same, considered as complicated UTI. Staphylococcal toxic shock syndrome. Staphylococcal toxic shock syndrome. This is a picture of staphylococcal scalded skin syndrome. There may be tampon use, there may be nasal packing, surgical or postpartum wound infection. It is done by the staph aureus and exotoxin releases acting as superantigens. Clinical feature: fever, hypotension, diffuse macular rash. 1 to 3 weeks after disease onset, vomiting, diarrhea may be present, altered mentation. Supportive therapy: fluid, removal of the foreign body tampon, and antibiotic therapy, Clinda and Vancos. Now, syphilis in pregnancy: universal at first prenatal visit, universal RPR video should be done to rule out STDs in pregnancy, HIV, RPR VTL, HVSAG, chlamydia and gonorrhea. Intramuscular penicillin G benzathine should be given. Intrauterine fetal demise and preterm labor happens in syphilis. In pregnancy, intrauterine fetal demise and syphilis. So for syphilis, pregnancy effect is intrauterine fetal demise and preterm labor, and fetal effects is hepatic, hepatomegaly, jaundice. There may be hematologic, hemolytic anemia, decreased platelet, muscular skeletal, long bone abnormality, and failure to thrive. Treatment with penicillin is required for all pregnant patients with syphilis to prevent complication. Patients with penicillin allergy should receive skin testing to confirm IgA-mediated reaction if the test is positive. Patients with desensitized to penicillin prior to receive treatment with intramuscular penicillin G benzathine doxycycline is contraindicated in pregnancy due to decreased bone growth. This is the 10-page at a row. Hope you will enjoy.